Welcome to the most awaited and the most interesting and most exciting mega panel discussion of the second Indian Myopia Awareness and the Research Conference. So the purpose of this mega panel discussion is to see or discuss mostly asked or frequently asked questions and see what are the consensus are among different panelists. I request Dr. Ramesh K. Kunaya to co-moderate the session along with me and invite all the speakers from the last session. Next slide, please. All right, Dr. Vivek Warkar, Dr. Jyoti Matalia, Dr. Vishwanathan Sivaraman, Dr. John Faber, Dr. Chandrasekhar Chavan, Dr. Dharani Ramamurthy, Mr. Rohit Dakal, Dr. Sampada Kulkarni, and Dr. Premnandini Sadguna. Of course, you will be sitting wherever you are, but Dr. KR, do you want to add anything before we start?
First of all, can you hear me?
Yes, we can hear you.
Okay. Thank you, Pawan. I think the goal of this session is just as a clinician and others, what kind of frequently faced problems, what we face, and also some kind of learning from this IMARC can we get to the practical situation of patient care. So that's a kind of summary for this kind of final panel discussion, Pawan.
Great. Thank you. I see Dr. Lisa Austin as well. Kindly make her the co-host. Lisa, thanks for staying so late. If possible, we will also drag you into this panel discussion. So first, before I ask any question to any of the panelists, are there any questions that you want to ask?
I have a question to ask.
Okay, this is
Dr. Jyoti.
This is
Jyoti,
Jyoti.
yes.
Go ahead, Jyoti. Yeah.
Yeah, so I want to ask, especially for people who are doing orthokeratology. So if we have somebody who has a very high astigmatism of more than say 2-4, so what are the various options? And can we still give ortho-K for the night and the remaining part of the day we give them glasses? Because we have scenarios where there will be very high astigmatism in these children. So what are the various options? Especially if you want to consider ortho-K also.
Yeah, thanks for that question, Dr. Jyoti. So traditionally they say that, the spherical component until 5 to 6, they can also take extra amount of the astigmatism. That's number one. Number two, studies have also indicated that partial correction with orthokeratology lenses and the remainder can be corrected with spectacle or contact lens. That's another option as well.
More so for children who are high myopes, like we are looking at somebody over -6 spherical and having a -2 astigmatism, for them, we can consider this as an option, right?
Correct.
Yeah. Okay. Fine.
Great.
Pawan, can you start my video, please?
Can you please allow all the panelists to turn on their video?
So Dr. Jyoti, yes, toric ortho-K is the solution, and nowadays almost 40 to 50% of our orthokeratology fittings are toric, because if there is a corneal astigmatism, it has to be tackled with toric lenses and not spherical component.
Right. So I just want to know till what level of toricity can you give the lenses?
So far we have up to -3.5 cylinder corneal toricity can be corrected.
Okay. And we have this available in India too, right?
Yes, of course nobody manufactures in India, but all the labs from the US will supply that.
Like basically distribution is possible here. That's what
It is there already. Yes.
We also have in the panel a specialist in ortho-K who has manufactured the lenses, Dr. John Faber. So can you please tell us your perspective on this, please?
Thank you so much, Pawan. Yeah, we can correct any astigmatism. The highest astigmatism I correct is -6 cylinder, pure cylinder. This is possible today. The problem is the distribution in India. That's the problem always. So I don't know, Chandra, he knows much better than I which lenses are available in India, for sure. But yes, there is the designs with toric periphery, with toric optical zone that we can achieve beautiful results. So we can correct high myopia and high astigmatism and good control myopia for that children. This is possible. The problem is always the same problem: distribution and manufacturing in India. That's always the same point.
Yeah.
So maybe can you tell us a bit more about how these designs are a bit different to the traditional ones, the ones you're talking about that could take up to minus 5 diopters of astigmatism?
Yeah, absolutely. Okay, basically, designs for spherical component of the cornea. This is usually they are 4 curved designs. Toric lenses are exactly the same, but we have two sagittal heads. So we have the flat cornea profile lens and the steep cornea profile lens. So we design a lens. This is a toric lens. And generally speaking, the 90% of the designs has a spherical optical zone, and then all the curves are toric. But if you want to correct the full astigmatism, full refractive astigmatism, you need to do a back optical zone toric as well. So this is at least what I know is only my design that is doing this at that moment, that corrects all the refractive cylinder. Other designs correct the corneal cylinder. But by chance in general, you will not find astigmatism higher than 2 or 2.5. That is quite weird. So in general, all the lenses you could have available in India, it will help to you to correct this. So basically what you need to do is a fitting that is making 2 steps. You need to look at the flat meridian, you need to look at the steep meridian, and you need to adjust the parameters of the lens in flat meridian, and you need to adjust the parameters of the lens in steep meridian, like toric lenses. And then you will have a good result. And it is easiest, even it is better, it is easy fitting a toric lens than the spherical lens in ortho-K, because when you fit a spherical design in a cornea that is slightly toric, in general you will have the centering.
Yes.
But when you are fitting a toric lens that is perfectly fit in the flat and steep meridian, the lens will fit perfectly in the cornea and will center perfectly. So this is not more complex. It's just you need to do 2 steps, but it's easiest than a spherical lens.
Yes, Jaume is very unique. He designs his own lenses. He can go up to any cylinder and any minus power. But in general, most of the labs in the US will help you up to minus 3.5. I've been helping Preeti Mistry in Mumbai, who's my associate. I design in US and send it to her. You can also take use of her. Here I would like to add one more point, since Jaume is also here. One has to consider the corneal astigmatism. If it is a with the rule astigmatism, it's straightforward, no problem. If it is oblique or against the rule astigmatism, you have to look whether you're actually talking about myopia control. Is the child is going to go into any further complications like keratoconus or other issues. That also needs to be thought of. There are genetical testings available. If you do a pentacam, you get more indices to work with. I think there was some paper somebody published. I was listening to someone yesterday who were talking about the same thing. So those things also to be considered when we are talking about myopia control.
Great. All right, let's shift gears from Jaume. You were going to say something.
Sorry?
You were going to say something?
Yeah, okay. In general speaking, horizontal, so with the rule astigmatism, it is quite easy, even if you use spherical lenses. But at the moment you have oblique or vertical, against the rule is much difficult. But indeed, if you have enough toricity in the cornea to fit your lens, the lens will adapt your cornea, you will correct as oblique and vertical astigmatism without any trouble. Other thing is to have a look if you have a suspicious of keratoconus. Even if you have a suspicion of keratoconus, that you need to do a pentacam and look the thickness of the cornea and see the posterior cornea elevation. If you have a form frustre, so the first stage of keratoconus, you could do ortho-K. even if you have a very thin cornea, you could do ortho-K, because we are just working with the epithelium. We are not working with the overall cornea. Of course, if we have some suspicion, suspect, we need to think that when we fit any lenses on eye, we increase the inflammation. It's a subclinical inflammation, and keratoconus is a inflammatory origin. Even if it's subclinic, we don't see it, but it's not longer a non-inflammatory condition. It's an inflammatory condition. So the moment you add a contact lens there, you increase the inflammation on the eye. So it could be something that could not go in the good direction for keratoconus. So be careful at that point. But it's just at the beginning, and it's just for frustrate. That is the most early stage. You could go ahead if it's not very high level of myopia to correct. Okay, yeah.
Thank you. So let's shift gears from the optical strategies to the pharmacological management, the mostly used atropine. And I see the very renowned pediatric ophthalmologists are in this panel. So let's hear from them. Well, we clearly know that atropine doesn't work for everybody. It works in a certain set of children, but it doesn't work in certain set of other children. Do you change the dosage as your next step, or do you go with the next concentration? Let's say we start with once at bedtime, it's not working. What's your next step? Do you increase the dosage, or let's say instead of using it one time at bedtime, once at bedtime, you go twice? Or would you change your concentration? Maybe I will ask Dr. KR to speak up on this.
Yes, Pawan. I think in the morning we had a bit of discussion about this. Most people around the world are comfortable in wherever they are in starting 0.01% in terms of starting it. And obviously, whatever is discussed till now, the astigmatism part should be minimal and very important to rule out the form frustic keratoconus and other things. I generally see the astigmatism part in Indian eyes are not that typical what you see in atom study. It's definitely more than 1.5, not in all the patients, but majority of the patients. In terms of atropine, my first strategy is to increase the dose, increase the dosage, that is OD to BD. Check for 1 or 2 cycles. Still there is a kind of progression. I would like an intermediate dose, which is unfortunately not available in India. We have to jump into 1%. Probably somebody should make that intermediate dose, which should really help, I guess, or at least we'll have data which concentration helps if 0.01 fails. 0.01, most of the people are comfortable because it's not that it's 100% immune to side effects. We also have seen side effects in even in 0.01%. But in terms of rebound effect and other things, it's very, very minimal. So my strategy is make it BD and then increase the dose. That's the way. Having said that, what is the percentage of this? I would say around 30%. I would like to hear from others as well.
Yeah, Dr. Jyoti, Dr. Vishwanathan, you've been practicing management of myopia with atropine. So what's your take on that?
One of the things, sorry, you want to go? Please go.
You can go ahead, it's okay.
Okay, Dr. Jyoti first and then maybe Dr. Vishwanath.
Alphabetically. Okay, so as Dr. Ramesh rightly said, since 0.01 is commercially available, that's the first take, and that's since everybody gets it, we tend to use it. Yes, but the amount of complications are relatively less, maybe because of Indian eyes. Now we are it's very apparent that as the dose of atropine increases, obviously the efficacy increases, but the fear is the rebound. So if 0.01 is definitely not working, we know our 0.05 is going to work. But since it's commercially available, my take on this is if it's not giving me the response I want, I go with twice a day. This is again, nothing is being confirmed, but just like once a day has been proved, unless we show that it doesn't work, we cannot really tell. So I have started my patients on 0.01, but twice a day. One other touch upon the astigmatism I want to say is lately, last couple of years, we've been doing a study in Narayanachala where we've realized that children have very steep corneas. In fact, if we go higher, you may get somebody at 48, but we always get a pentacam done which rules out a patient of keratoconus. What really happens is